Thank you. And okay, here we go. Thank you, Dr. Anuradha, to set the floor set for me to speak about the unblocking the unmet need in MET exon 14 mutant non-small cell lung cancer. These are the disclaimers. And my first reactions when I first saw this talk about unblocking the MET exon pathway was like this. MET here is basically not about capmatinib and tepotinib and savolitinib and everything. Met exactly today and yesterday was where did Vicky meet Katrina for the first time? And my subsequent reactions at that time, and please note the color combination red and red in the marriage occasion, was didn't you know? I mean, at least I didn't know till around 7 days back that they were getting married together. Like I didn't know what about Vicky Kaushal and Katrina Kaif. I also didn't know that MET. I thought just came a year or 2 year back, but that's the timeline of actually MET inhibition. MET as a gene was identified in 1984 or 1986. In 2005, the MET exon 14 splicing mutation basically was reported. In 2018, crizotinib was approved for MET exon 14 splicing. And in 2019, capmatinib and tepotinib really came in a big way and were approved for this mutation. So, I mean, that is where we all were. So, like we had, at least I had no clue about Vicky Kaushal and Katrina Kaif. I had no clue about what was happening in the MET space also till around 1 year back. And that's a thing which actually should be there for all of us, at least for me. Wake up. There is more to life in lung cancer that is actually been happening over there. So let's talk about MET14 alteration in lung cancer. I'll just like to tell you briefly that they are present in 3% of non-small cell lung cancer patients, mostly older females, former or current smokers. I'll come to that. But it is present in 20% of pulmonary sarcomatoid carcinomas, and that is something which is very, very important. So the moment you have a sarcomatoid carcinoma, we should definitely go and test for these mutations. Now, MET mutation, good or bad, it is a bad prognostic factor. If you have a MET positive tumor, they are associated actually with worse survival. You can see the purple curve over here, and you can see the gray curve on the below side, which basically says that an untreated MET exon 14 is associated with a worse survival. Now, what about immunotherapy? And as I open the slide, immunotherapy, Dr. Sevanti Lime suddenly appears on the screen. So maybe immunotherapy is synonymous with Dr. Sevanti Lime. But MET exon 14 also is associated with a poor response to immunotherapy, with a median PFS of 1.9 and a median overall survival of only 18.2 months. However, so immunotherapy doesn't work, generic chemotherapy doesn't work. But if you have a MET inhibition in any of the MET mutated stage 4 non-small cell lung cancer, your survival increases from 8.1 months to 24.6 months, which is absolutely fantastic. Now, the MET inhibitors are not one. MET inhibitors can be type 1A, type 1B, type 2 TKIs. It basically depends upon how they bind the ATP pocket in the active conformation or they bind it in the inactive conformation. But more importantly, if you say the IC50 for crizotinib, that is the type 1A MET blocker, is 22.5, and compare that with capmatinib, which is only 0.06. So basically, capmatinib is a very selective, highly potent MET blocker in its regular dosages. You are not alone. MET exon 14 alteration. The first thing to come actually was crizotinib. In fact, we have a paper in which we have given crizotinib to 4 or 5 patients, and this in the 001 trial showed an overall response rate of 35% with a median response rate of PFS of around 7.3. However, capmatinib does not cross the blood-brain barrier, and please remember the median PFS of 7.3 months actually over here. That brings me to the subject of today's trial, that is capmatinib. That was the geometry trial, a very complicated study design, in which you have 7 cohorts actually. I will be talking about the only the 2 cohorts to start with, that is the 4 cohorts, cohort number 4 and cohort number 5B. So easy, you have a MET exon 14 mutation detected, irrespective of MET copy gain number by a central RT-PCR, were given capmatinib 400 mg BD. Cohort 4 was the pre-treated, cohort 5B was the naive. So easy, you have cohort 4, which is pre-treated, cohort 5B, which is basically treatment naive. And this is a very important slide as far as I am concerned. It basically shows that females accounted for 60 to 65%, Never smokers accounted for around 65%, adenocarcinoma in 80% of patients, brain metastasis in 15% of patients. What it also shows me actually is that 35% of males who are smokers, 35% of smokers and squamous cell carcinomas also will have a MET exon 14 splicing mutation. So we should definitely test for people. A male smoker, tendency is to not get an NGS done. But I think with in a squamous cell, so now that calls for one more extra point, that maybe we should do NGS in all our patients, except rather than looking only for females and all. And we have actually changed our practice from a single gene testing to a NGS for almost everyone. Now, again, exon code, if you look at the cohort 4, you have an overall response rate of 40% with a disease control rate of 75%. But if you look at the cohort 5B, you have a 65% rate overall response rate and a disease control rate of 95%, which is absolutely fantastic for a first-time capmatinib like this. Again, the responses were rapid. If you can see over here, the responses were deep, and the duration of responses also was 9 months in cohort 4 and 14 months in cohort 5B. Compare this with the crizotinib data, which was only around 7 months, I guess. Again, very, very important point is that the tumor shrinkage by MET alterations, very important point is you can either detect the exon 14 splicing mutation by RT-PCR or by NGS, a high concordance rate. But if you have a exon 14 mutation detected, please treat them with capmatinib and all of them will have a fantastic report. Now, this was the 2020 data by Wolf et al. PFS of 6 months in second line setting and the PFS of 10 months in the first line setting was basically observed. Very, very importantly, capmatinib crosses the blood-brain barrier, which is, you can have a look at the lesions over here and you can have the lesions over here, which is absolutely fantastic. So intracranial disease control rate was also seen in 12 by 13 patients. This was the 2020 data. Now, what happened in 2021 data was that they presented in the ASCO 2021. Now, you had cohort 4 and cohort 5B. Now, they got expansion cohorts over here, cohort 6 and cohort 7 also over here. Now, what this basically showed was expansion cohort 7 was again a response rate of 67.9 and 65.6 with a disease control rate of 96.4 versus 100%. The moment I say disease control rate of 96, 97, 100, the only picture which is coming onto my screen is Nirmal Roth's. So probably Nirmal Roth is also used to getting 100% marks. We are on this normal rate of 67, 66% actually. Even in second line, you have a 51% and 40.6% people who are responding in second and third lines also, which is again very, very important. And this is absolutely fantastic. A 20.8 months OS in the first line and 13.6 months in the second line was actually observed over here. So to conclude, overall response rate of 68%, disease control rate of 97%, durable responses, deep responses, rapid responses, a median overall survival of 20.8 months in the first line. And definitely this is for Novartis and MET, all our patients who have an exon 14 splicing mutation. This calls for a celebration. But celebrations are not the only thing over here, because Novartis is not alone in getting capmatinib. And here is where my sponsored session talks ends. And I'll talk about more about science now. You have 3 more inhibitors, tepotinib, and savolitinib and capmatinib, obviously. And here, Vision trial showed basically that MET exon 14 was detected by plasma. And what they basically did was that again they found out that the median PFS was 9.5 months and the median in the tissue biopsy it was 10.8, it was 12.2. So if you have a lot of MET inhibitors, how do you decide? So if there are people who are awake still, I think I would just like to show here. I think crizotinib basically goes out of equation with a low response rate with everything. I think crizotinib goes out of the thing. Capmatinib in the first line has the highest median PFS rate of 10.8 and an overall survival of 20.8 with a response rate of 65.6%. Tepotinib works the same whether it is the first line or second line. Savolitinib almost by the same. So as far as I am concerned, capmatinib has the highest response rate, the good PFS in 10.8, large number of patients, and the only trial to show some kind of OS data in the first line. Now, why should MET inhibitor? Second question which comes is that 2 more questions I'll ask. One is what MET inhibitor? Capmatinib is available. We should use that. Second is what about the role of immunotherapy in MET exon 14 non-small cell lung cancer patients. Again, when I say immunotherapy, Nirmal Roth's screen lights up. So maybe they are the guys for immunotherapy. But if you look at the ICI outcomes, which I have just told you on the left side, you have a response rate of 17%, PFS of 1.9 months, PDL1 was not predictive, low TMB. If you compare that to the geometry data, you basically have a PFS of around 12 months and with a very good OS advantage. So probably for me, immunotherapy also doesn't work. Again, last 3 slides, please. This is just a comparison of if somebody has got a PDL1 more than 50%, you have an overall response rate of 44.8.
Ullas sir, we need to conclude.
1 minute, just 1 minute. And capmatinib has 68% of a response rate. So probably a better overall response rate, similar PFS. The efficacy of capmatinib is better when given in first line. So maybe probably we should actually go ahead with the first line. Side effects were by and large okay. One side effect which is there is increasing creatinine. Don't bother about that because it is basically caused by the inhibitor of renal MATE transporters. Forget my experience. Somebody is going to speak about that. So in my last concluding slide, exon 14 splicing mutation should be tested by either PCR or NGS, RNA-based NGS. Capmatinib is a potent MET TKI inhibitor. And the journey of MET in non-small cell lung cancer is basically from Vicky Kaushal to when they met to so glad that they met and, we didn't get invited to the wedding. With that, maybe Dr. Sevanti went for the wedding over there. So with that, thank you. Thank you for giving me an extra minute to show Vicky Kaushal's photograph and hand it back to the organizers. Thank you.
Thank you so much, sir.
Ullas sir, I have a question for you, Vijay here. Would your choice change if it is MET amplified? No mutation,
Yes.
MET amplified.
Yeah. So MET amplification, the data just came. First of all, we don't know what is the level of MET amplification that we're talking about. Whether we're talking about 6, because tepotinib in the vision trial by liquid biopsy took it more than 2.5. So for more than 6 or more than 10, I will not really use in the first line. In the second line, I would give capmatinib. No doubt about that. But not in the first line.
Okay.
Okay, thank you, sir.